Hello, doctors and clinical researchers. Thank you for your hard work today with lung and liver transplant surgeries, anesthesia, and post-operative care. Today, we will learn about simultaneous liver and lung transplantation. Hola, doctores e investigadores clínicos. Welcome to this clinical masterclass explainer. As specialists navigating the absolute frontiers of multi-organ transplantation, you know that this procedure is one of the most formidable challenges in modern medicine. Over the course of this deep dive, we are going to thoroughly unpack the hard data, the intense debates around surgical sequencing, the evolving role of extracorporeal support, and the fascinating immunology that defines this incredibly rare intervention. Let's get right into it.
Here is our clinical syllabus for today. First, history and indications. Second, patient selection and ethics. Third, surgery and anesthesia. Fourth, outcomes and complications. And finally, immunology and the future.
Section 1, History and Clinical Indications. Let's look at the overlapping pathophysiology that brings a patient to this critical point.
To truly appreciate combined lung and liver transplantation, or CLLT, we have to look at the historical timeline because it highlights just how exceptionally rare and specialized this procedure is. It makes up less than 0.01% of all multi-organ transplants. Our timeline starts back in 1986. That's when the very first combined heart-lung-liver transplant was pulled off in Cambridge by Professor Roy Cowan and John Walwork, a monumental achievement. The first successful CLLT in the United States didn't follow until 1994 at the University of Illinois. And to give you a real sense of the extreme rarity here, by the year 2016, the entire ISHLT registry had recorded only 131 cases globally. Looking at current UNOS data in the US, we're talking about just over 103 cases performed to date. This isn't a routine procedure. It is a highly specialized, desperate intervention reserved for the most complex clinical scenarios you'll ever face.
Because of the intense, hyper-coordinated, multidisciplinary expertise required, these surgeries are overwhelmingly concentrated in a very select group of pioneering high-volume centers. Let's look at the numbers. In the U.S., Houston Methodist has performed 14 cases. Duke University has done 15. The Cleveland Clinic sits at 10 cases. Now, contrast that with the rest of the landscape. 21 other centers have performed 5 or fewer of these procedures in their entire institutional history. This extreme centralization isn't an accident. It perfectly highlights the absolute necessity for flawlessly coordinated surgical, pulmonology, hepatology, and anesthetic teams to manage these incredibly fragile patients. You need a massive institutional infrastructure to even attempt this.
So what's driving this dual failure? Let's break down the pathophysiology. Cystic fibrosis is our classic, most common indication. As you know, the CFTR gene mutation causes widespread chloride channel dysfunction. And while bronchiectasis and progressive airway stenosis are what typically drive mortality, we see that 22 to 47% of CF patients develop CF-associated liver disease. Even more concerning, 5 to 10% progress to full multilobular cirrhosis with portal hypertension, often in their very first decade of life. Alpha-1 antitrypsin deficiency similarly attacks both organ systems, with 19 to 43% of these patients developing cirrhosis. But what's truly fascinating and a huge shifting trend in our field is the expanding awareness of concomitant liver disease and other lung conditions. Look at this. 61.3% of COPD patients exhibit liver fibrosis, and 32 to 35% of idiopathic pulmonary fibrosis patients show fibrotic liver changes. Systemic sclerosis sits at 9 to 27% for cirrhosis. We are also increasingly seeing combined failure in conditions like portal pulmonary hypertension and hepatopulmonary syndrome. In those specific scenarios, attempting an isolated liver transplant carries prohibitive, sky-high perioperative mortality if intrapulmonary shunting or severe right heart failure is already present.
Section 2, Patient Selection and Ethics. This is where we transition to the critical triage phase, detailing exactly how we evaluate these complex candidates.
This flowchart brilliantly illustrates the rigorous, non-negotiable triage required. We're looking at the UPMC clinical algorithm for cirrhotic lung transplant candidates. The core principle here is that every single lung transplant evaluation absolutely must include a thorough liver workup. For high-risk patients, those with CF, AATD, or known cirrhosis, we start right here with a right upper quadrant Doppler ultrasound alongside LFTs, INR, platelets, and an abdominal CT. If we spot cirrhotic echo texture or varices, we cannot stop there. We move directly to a liver biopsy and, crucially, we measure the transhepatic pressure gradient, or THG. Now pay attention to this threshold, because it's a matter of life and death. A THG of 10 to 12 millimeters of mercury is the line in the sand. If you have a child's A or B patient with a gradient below 10, they just might tolerate an isolated lung transplant. But if that gradient is above 10 to 12, or if they are in child C cirrhosis, an isolated lung transplant is definitively contraindicated.
Why? Because the hemodynamic stress of the thoracic surgery will cause catastrophic, irreversible postoperative liver decompensation. These are the patients who must be referred for a combined listing.
Once a patient is actually listed, how do our standard allocation scores predict survival? Data from Dr. Stephanie Yee's 2013 Houston Methodist cohort provides some absolute crucial insight. They discovered that CLLT candidates with a lung allocation score, or LAS, of less than 50 achieved a remarkable 100% one-year survival. On the flip side, patients with an LAS greater than 60 suffered severe perioperative mortality, overwhelmingly driven by sepsis. Now, here's the interesting paradox. The median MELD score for these dual-organ patients is surprisingly low, typically sitting between just 9 and 12.5. That's because the primary urgency driving the patient's decline is their end-stage pulmonary disease, not hepatic synthetic failure. This glaring discrepancy creates a massive challenge in modern allocation systems. When you look at Eurotransplant's approved combined organ policy versus the recent US OPTN 2024 updates, we are constantly trying to carefully balance immediate respiratory urgency against relative hepatic stability. It's a very difficult tightrope to walk.
Which brings us to perhaps the most profound ethical debate in organ allocation today. Do these combined lung-liver recipients truly need the liver, or could they survive with an isolated lung transplant? The data here is polarizing. On one hand, Dr. Freischlag's 2019 propensity-matched data from Duke showed that one-year survival for combined transplants was 89.5%. That is almost identical to the 86.7% survival for isolated lungs. Incredible results, right? But then, look at Purvis's 2021 UNOS analysis. They compared combined transplants to isolated liver transplants and found a hazard ratio of 2.05. That means combined recipients had significantly worse outcomes than those receiving a liver alone. This sharp contrast has sparked urgent calls for strict medical necessity criteria, very similar to the simultaneous liver-kidney guidelines we already use. The goal is to ensure we are not utilizing incredibly scarce liver grafts in patients whose hepatic disease might not genuinely warrant it, while at the same time not abandoning the patients who will absolutely die without receiving both organs.
Section 3. Surgery and Anesthetic Management. Let's head into the operating theater and discuss the physiological marathons these teams run.
A major point of ongoing controversy in the OR is the surgical sequence. Which organ goes in first, and how does that choice impact organ preservation? Let's break down the two main philosophies. First, we have the traditional American approach, which is lung first. The rationale here is purely physiological. Lung tissue is exquisitely sensitive to cold ischemia. By utilizing preservation solutions like Perfidex and transplanting the lungs immediately upon arrival, you heavily mitigate ischemic injury to the pulmonary graft. However, the trade-off is brutal. The patient's failing native liver remains in the body during the entire thoracic surgery, which wildly exacerbates coagulopathy, massively increases bleeding, and significantly raises the risk of primary graft dysfunction, or PGD, in the new lungs. Now contrast this with the Hanover approach. Pioneered in Germany in 2006 and recently utilized in Poland's very first CLLT case by Ehrlich in 2022, this approach advocates going liver first. Yes, the donor lungs have to sit on ice longer, increasing their cold ischemia time. But transplanting the liver first rapidly corrects the patient's systemic coagulopathy before the chest cavity is even opened. The latest data shows this sequence drastically reduces massive transfusion requirements, lowers the incidence of severe PGD, and remarkably seems to significantly reduce the risk of future biliary strictures. It's a fascinating trade-off in organ preservation and patient stability.
The choice of extracorporeal support during these sequences is absolutely critical, and the latest data is definitive. Using traditional cardiopulmonary bypass, or CPB, triggers a severe, massive catecholamine surge in the patient. This causes a devastating 45% reduction in hepatic arterial blood flow and an overall 20% decrease in hepatic perfusion. That kind of massive ischemic hit is a leading cause of post-transplant hypoxic hepatitis, destroying the new liver you just implanted. Because of this, modern high-volume centers strongly, almost exclusively, prefer veno-arterial ECMO. VA ECMO provides far superior hemodynamic stability without that dramatic vascular clamping effect, resulting in a much lower risk of acute liver failure. Regarding the surgical technique itself, biliary reconstruction must be meticulously planned, based on the patient's underlying disease. While an end-to-end choledodoxygenostomy is very common, a Roux-en-Y reconstruction is frequently utilized in cystic fibrosis patients specifically to prevent ascending cholangitis. And for the rarest, most extreme cases, such as the famous Cambridge series detailed by Procidom in 2001, an en-bloc heart-lung-liver technique can actually be utilized, transplanting the thoracic and abdominal organs all together as a single, continuous hemodynamic unit.
From an anesthetic perspective, the most terrifying intraoperative complication we face in these cases is vasoplegia. We define this clinically very specifically. It's a mean arterial pressure of less than 60, paired with a high cardiac index, greater than 2.2, and a profoundly collapsed systemic vascular resistance of less than 800. And this happens despite slamming the patient with high-dose vasopressors. The incidence in transplant surgery is staggering. We see it in 29% of heart transplants, 28% in lungs, and 11% in livers. So in a combined lung-liver case, the risk is massive. The pathophysiology is driven by an intense systemic inflammatory response, overactivation of nitric oxide synthase, cyclic guanylate cyclase issues, massive cytokine release, and absolute vasopressin depletion. And we know the risk factors: prolonged ECMO or CPB times, extended organ ischemia, pre-existing infection, and preoperative use of ACE inhibitors or ARBs. It's a perfect storm for vascular collapse.
Managing this highly specific type of distributive shock requires a rigid, stepwise pharmacologic cascade, heavily echoing Ardaleva's recent 2025 framework. We don't guess, we follow the steps. Step 1. We begin with conventional high-dose catecholamines combining norepinephrine with vasopressin or terlipressin to try and forcefully restore vascular tone. If the patient remains refractory and their pressure is still bottomed out, we move to Step 2, methylene blue, which directly blocks nitric oxide signaling. Step 3 is hydroxycobalamin. And finally, Step 4, we deploy angiotensin II. But here's where transplant anesthesiologists must be incredibly cautious. In liver recipients who have underlying portal pulmonary hypertension, pushing methylene blue can dangerously precipitate acute right ventricular dysfunction. Furthermore, slamming the patient with these profound vasopressors can severely alter the metabolism of your intraoperative immunosuppressive drugs. And critically, it starves the vital splanchnic perfusion needed to keep the new liver graft alive. It's an incredibly delicate balance.
Section 4. Clinical outcomes and complications. Let's move away from the OR and look at the hard clinical evidence regarding long-term survival and morbidity.
Looking at the evolution of one-year survival data over the decades, we see a very clear, encouraging trajectory of improvement. Back in 2005, Barshes reported a 79% survival rate using UNOS data. A few years later, the Hanover experience, published by Grannas in 2008, showed a dip to 69%. By 2013, Yee's cohort at Houston Methodist achieved 71.4%, but they noted something vital. Optimal candidate selection, specifically those with an LAS under 50, yielded significantly better results. As our surgical techniques matured, and specifically as ICU shifted from CPB to ECMO, the numbers jumped. Freischlag's 2019 propensity match study demonstrated a truly impressive 89.5% one-year survival, and Purvis's 2021 analysis showed 82.5%. What this timeline beautifully illustrates is that, in the modern era, the survival outcomes for a vastly complex combined lung and liver transplant have become remarkably comparable to the outcomes of isolated single-organ transplants. That is a massive triumph of modern medicine.
But despite those incredible survival gains, we have to be realistic. The postoperative period is absolutely fraught with danger. Sepsis remains the single leading cause of perioperative mortality, and this is largely due to the profound, multi-resistant preoperative bacterial colonization we see in our cystic fibrosis patients. When we look at long-term survival, it is almost entirely dictated by pulmonary complications, specifically chronic lung allograft dysfunction, or CLAD, and bronchiolitis obliterans syndrome. Surgically, we are constantly battling the risks of bronchial anastomosis ischemia and bile duct ischemia, or leaks. Furthermore, as Heisney detailed in 2021, if you look at patients who only receive a lung transplant but have underlying liver fibrosis, we see a massive 6.9 to 28.4% incidence of severe postoperative liver dysfunction. This strongly reinforces the hypothesis that the oxidative stress of prolonged hemodynamic support systems and heavily hepatotoxic post-op medications can easily and rapidly overwhelm a marginally fibrotic native liver.
Section 5. Immunology and future directions. Now we get to explore the truly unique immunobiology of combined transplantation and look at what's coming next. This is perhaps one of the most fascinating phenomenon in all of transplant medicine. Ever since Sir Roy Callan's early groundbreaking experiments with porcine models back in 1969, we have known about a concept called liver immunotolerogenicity. Here's how it works. When a liver is transplanted alongside another organ, like a lung, from the exact same donor, the liver actually exerts a profound, systemic immunoprotective shield over that secondary graft. It physically acts as an immunological sponge. The massive endothelial surface area of the liver absorbs circulating donor-specific antibodies, drastically promoting systemic tolerance. In actual clinical practice, What this means is that acute rejection of the liver allograft in a combined transplant is exceptionally rare. It's almost non-existent in most major case series. Now, pulmonary rejection absolutely still occurs, but its overall severity is frequently blunted by the liver's presence. This incredible shield allows us to carefully tailor our immunosuppression protocols. We've largely shifted away from the older, harsher cyclosporin-based regimens, moving toward modern, optimized tacrolimus-based triple therapy with mycophenolate, mofetil, and steroids. This maximizes graft protection while minimizing long-term renal toxicity.
And this chart beautifully illustrates the real-world impact of all these clinical and immunological advancements. When you track the UNOS registry data from 2004 all the way to 2018, there was a clear, steady, undeniable global growth trajectory in the number of combined procedures being performed annually. We've moved from doing just 2 or 3 highly experimental, sporadic cases a year to a consistent double-digit volume worldwide. This growth isn't random. It is entirely driven by our advancing surgical techniques, the massive paradigm shift from cardiopulmonary bypass to VA ECMO, and the continuously expanding institutional experience at these select, high-volume centers. We are transforming what was once viewed as an experimental, almost impossible last resort into a highly standardized, life-saving therapy.
As our clinical confidence and technological capabilities grow, so do the indications. We are now seeing the successful management of incredibly complex, unprecedented special cases. Just recently, in 2024, Oliveira reported the very first successful CLLT in a patient suffering from hemophilia A massive surgical and hematological triumph. Back in 2020, Zhang and colleagues at Baylor detailed an astonishing case involving a CF patient with hepatopulmonary syndrome. This patient underwent a bilateral lung and liver transplant, and then, navigating absolutely massive fluid shifts and hemodynamic instability, underwent a delayed right kidney transplant. Furthermore, we are becoming highly adept at managing devastating long-term oncological complications like post-transplant lymphoproliferative disease, or PTLD. We are now successfully using targeted biological therapies like rituximab to rescue these incredibly fragile dual graft recipients without destroying their transplanted organs.
So, what lies immediately ahead? 2 massive paradigm-shifting innovations are reshaping this entire landscape. First, heavily highlighted in Zhang's 2024 publication in Seminars in Liver Disease, is the advent of normothermic machine perfusion, or NMP. By keeping donor organs warm, oxygenated, and fully metabolically active ex vivo, NMP could entirely eliminate the lung-first versus liver-first sequence debate we discussed earlier. Think about it. We will no longer be frantically racing against a cold ischemia clock. This allows for meticulous, unhurried surgical correction of the patient before implantation. Second, the rapid development of highly effective CFTR modulators is radically altering the natural history of cystic fibrosis itself. By halting the disease progression at a genetic level early in life, these pharmacological therapies may drastically reduce the number of CF patients who ever progress to dual organ failure in the first place. This means the primary demographic for CLLT is likely going to shift away from young genetic patients and move toward older adults suffering from independent acquired fibrotic diseases.
Which leads us to a final, provocative question that every transplant professional needs to consider. As non-transplant pharmacological therapies, like those new CFTR modulators, continue to evolve and intercept disease, and as our surgical survival rates for combined transplants now equal the survival rates of single organs, how will we, as a unified international medical community, standardize global eligibility criteria for combined organ allocation? In an era of extreme, persistent donor shortages, we have an absolute, urgent clinical need to establish universal, data-driven parameters that clearly define true medical necessity. We have to ensure that these incredibly precious, life-saving dual grafts go to the exact patients who need them most, without wasting a single viable organ. Thank you for joining this Masterclass Explainer today. Let's keep pushing the boundaries of clinical science together.